Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is tympanometry. So, learning objectives for the current presentation is that by the end of the session, students should be able to define tympanometry and what is its purpose in clinical practice. Explain the principle of the middle ear pressure and compliance measurement. Identify the normal and the abnormal tympanogram types. Interpret these findings in relation to common ear pathologies like otitis media, ossicular chain issues, and eustachian tube dysfunction, and apply these tympanometry results in planning the patient management. So, what is tympanometry and why is it important in ENT practice? Tympanometry is a non-invasive audiological or acoustic investigation. So, best term is audiological investigation. It is an objective test. Remember, for audiometry, which is a subjective test, so it is an objective test and patient has no control in the results. Yes, patient has to cooperate in one two things like during the test he don't have to swallow or yawn, otherwise it will affect the result. It is used to assess the middle ear functions. It measures the compliance, which is the movement of the eardrum, and stiffness. So if the eardrum is thick or not move too much, then it means it is stiff. Of the tympano-ossicular system, meaning of tympanic membrane and the ossicles attached to it. So that is the tympano-ossicular system, meaning the mobility of the tympanic membrane and the ossicles. So due to this compliance, it provides a graph in response to air pressure, and that graph is known as tympanogram, not tympanograph, tympanogram. So by definition, tympanometry is an objective test that measures the mobility of the tympanic membrane and middle ear system by varying air pressure in the ear canal and recording the sound energy reflected back in the form of a graph. Okay. So the equipment basically is the tympanometer with the tympano probe, which includes the loudspeaker or a probe tone from which sound is produced. Then a microphone which detects the reflections of the sound energy, and the air pump which will vary the air pressure. And what is the output result? It is in the form of a tympanogram. So the principle of tympanometry, it involves a small probe. That probe is placed inside the external auditory canal. Now inside the probe, it consists of an air pump, a microphone, and a tone generator or a loudspeaker, just mentioned in the previous slide. So this probe tone, it will delivers a pure tone, a single frequency tone of around 226 Hz. Previously it was 220 Hz, but now with advanced 226 Hz, which is considered more specific. This sound which is produced, it strikes the tympanic membrane and cause its mobility. Some of the sound energy it will be absorbed while the rest is reflected back. So this reflected sound, it is picked up by the microphone, and that intensity of reflection will show how much compliant will be in response to pressure the eardrum is. The air pump, it varies the air pressure in the ear canal from positive to negative, from plus 100 to plus 200 dpa to minus 400 dpa. Graph plotted between the compliance, which is the mobility of eardrum, in response to the varying pressure. So this is the picture which is showing this probe which is placed inside the external auditory canal. So this is the external auditory canal and the probe with three small points one containing the air pump, then a tone generator and a microphone. So whenever a sound is generated, it strikes the eardrum, causing the mobility of the tympano-ossicular system. The some sound energy it will be absorbed, while rest is reflected back, and it is collected or sensed by the microphone or received by the microphone to plot a graph. And this air pump, it will change the pressure from plus 200 to minus 400 decapascals, DEPA or decapascals, which is a unit for pressure. So this again the rough diagrammatic representation, how the tone it will go, prootone, and strikes the eardrum, and the thing which I have explained, it will go on further. Important to notice that at extreme pressures, positive, which is plus 200, or negative minus 400, the ear, I mean extremes of pressure, it's not only plus 200 or minus 400, but at extremes of pressures the eardrum becomes stiff, meaning less sound passes, as stiffer tympanic membrane reflects more sound energy than the compliant one. At the ambient pressure or the middle ear pressure, which is around 0 dpa, the eardrum moves the best and maximum compliance will be seen. So at positive or negative pressure, the tympanic membrane becomes stiff and there will be low compliance, while at equal pressure there will be maximum compliance with peak of curve. So this is the flow chart of principle of tympanometry. That probe is inserted in the ear canal. Probe tone or pure tone 226 Hz in adults, 1000 Hz in infants it will be delivered. Air pressure it will be varied in ear canal from plus 200 to minus 400 dpa. Microphone will measure the reflected sound, and compliance will be calculated, and graph plotted, which will be tympanogram. So this is the machine in our hospital. This is a tympanometry. This is the probe which is placed inside, and on this you can push the button when the ear canal is sealed with the probe. So how to apply this? You will, with a headband, you can apply this part to the head, and the other hand will be free, so you can place the probe inside and press the start button here. There are other types of tympanometry as well. This is a handheld tympanometry, so this you can carry it anywhere, and this the other machine, and we'll see how. So for that other machine you just have to put the probe inside and don't have to push any button, and it will automatically plot a graph. And same for this handheld, you have to just place it inside. Sometimes we may have to pull the pinna upward, backward, and laterally, so it will snug in comfortably the probe. So again, when you put this probe inside the ear canal, press the button, a graph will be plotted. So this graph is the tympanogram. So a tympanogram provides a graphical representation of the functioning of eardrum, which is the compliance, in response to changes in air pressure within the ear canal. So in response to the compliance with varying air pressure in the ear canal, a tympanogram will be formed. So normal tympanogram is labeled as A. These are the normal ranges. So whenever we plot a graph, which I'll show you in the next slide, there are certain parameters which you have to observe: the pressure, the mobility, and the external canal volume. And you must memorize what are their normal values to pick up the abnormality. So the middle ear pressure, it ranges from plus 50 dpa to minus 100. In some cases even plus 100 to minus 100 is considered normal, but it again depends on the symptoms of the patient as well. But for best concern, plus 50 to minus 100 is the normal value. The compliance, which is the mobility of tympanic membrane, it again ranges from zero point 0.3 to 1.5 milliliter. And the ear canal volume, it is up till 2 milliliters. Okay, so just remember 2 mils, which will be a normal value. Don't have to remember what is normal in the children, but up till 2 mils will be the normal value. So when we plot a graph, so this is the printed form of a tympanogram. So you have to mention the name, the gender, age, address, operator who is performing the uh, test, and the notes or the report of this graph. So if you see, the maximum peak is at around 0 DEPA, 0 pressure, or here it is written -3, -3. Compliance or the movement, it is 0.43, which is within the normal range of between 0.3 to 1.5. And external canal volume is also less than 2, so it is again normal. And this gradient, basically it is the width of the tympanogram, half of the width of the tympanogram from this part to this part. So it is 49 and 52. It is again measured in DEPA. So this is type A tympanogram. So again, this is what is captured from the screen of the machine. So the frequency is 226 Hertz. This is red on the right side. DEPA is given here 5, compliance 0.5, and external canal volume is 1.18. So these are normal values, and this blue it is of the for the left side. So for normal tympanogram, the middle ear pressure will be in normal range, compliance will be normal, peak will be at around 0 DEPA, but within that pressure range of minus 100 to plus 50. That is the normal range, and it will show normal middle ear function. So the otoscopic finding of the ear will be like this. The eardrum will be normal. Now some abnormal tympanograms, uh, there are basically two types major. One in which the pressure will be normal and compliance have problem, and in the second one there will be problem with the pressure. So for normal pressure, one with the low peak will be AS, one with the tall peak will be AD. Type C, or the peak in the negative pressure, is C, and one where there is no peak at all at any pressure, it is a flat or type B. So now we'll come individually. Tympanogram type AS. AS is basically shallow graph or low compliance. The peak will be reduced. You see, if we see here compliance, it is 0.19, and the normal value, as I mentioned, was 0.3 to 1.5. It is present when there is stiff ossicular system. So it means the compliance or movement of eardrum is very restricted, and it happens when the ossicular system will be too much stiff or the movement is affected. It is basically seen in ossicular fixation like in otosclerosis or Malleus head fixation. But since otosclerosis is the most common, so whenever question for AS will be given, the main diagnosis is otosclerosis. Then in some cases of tympanosclerosis, which is the chalky white deposits, it can also affect the tympanic membrane and the ossicles, causing stiffness in this tympano-ossicular system and restrict the mobility. So it can also occur. Graph finding will be the compliance will be low, but the pressure will be in the normal range. Otoscopic findings, as I mentioned, this chalky white deposits, tympanosclerosis is here. Most of the time in otosclerosis, the eardrum will be normal. Okay, so the two most common conditions of the conductive hearing loss in which eardrum looks normal is otosclerosis, and second is ossicular discontinuity. In some cases of otosclerosis or active otosclerosis, there will be reddish hue on the promontory. Okay, so this is known as Schwartz sign, but it is only present in 10 to 20% people, not more than that. Now, second is the tympanogram type AD. So there will be tall and broad peak, there will be increased compliance, and it will be present in hypermobile tympano-ossicular system. Main cause is ossicular discontinuity, because once the connection has lost, so eardrum will move as the ossicles and muscles which are attached to these ossicles, they restrict the excessive movement. Second is when the eardrum is very much thin. Okay, so it can also affect the mobility, causing in a way it causes hypermobility. A hypermobile tympanogram with an unusually high peak, which can result from healed perforation. And why? Because when there is perforation in the eardrum and it has healed, the fibrous layer, the tense layer, it will not be present there. So the tympanic membrane will be thin. It is also known as monomeric membrane due to the absence of eardrum's normal fibrous layer. And the graph finding will be compliance will be high, which will be greater than 1.5 mils, but the pressure will be normal. So like in here, if you see, the pressure is minus 91 in this picture and 6 dapa in this picture, but the compliance, it is more the way above than 1.5, around 3, but ECV is also normal. So this is type AD. So one cause, as I said, in ossicular discontinuity, there will be normal eardrum. But thin tympanic membrane will appear like this and healed perforation like this. So in these cases, the uh, tympanometry may be normal or it may be show AD graph. So it will be differentiated whether it is a normal finding or the patient has problem by testing audiometry or the tuning fork and the whisper test. If there is normal hearing, then it is of no concern, this type AD. But if the hearing loss is there around 50 decibel or more, then it means it is ossicular discontinuity. Type C tympanogram. Now the peak will be there, but it will be shifted towards the negative pressure. The peak will be normal or slightly reduced, and it is usually suggests the eustachian tube dysfunction. Now eustachian tube dysfunction, there can be many reasons. Upper respiratory tract infections, which includes the tonsillitis, sinusitis, rhinitis, and so forth. Whichever upper area which affects the eustachian tube will lead to eustachian tube dysfunction. And in non-allergy, non-infective conditions like allergic rhinitis, vasomotor rhinitis, it can also lead to eustachian tube dysfunction. Or this type C can also be present in resolving or early otitis media. So one question can come, or anybody can ask you, if a patient has type B, which we'll see next graph, and now after treatment it has become type C, so whether it has improved or it has deteriorated. So answer will be it has improved, because previous in type B there will be no peak, it will be simple flat, but now peak is there. It means it was immobile, the eardrum, or compliance was not there, but now with treatment the compliance has been returning back but not normal, so treatment needs to continue. So the graph finding will be compliance will be normal between 0.3 to 1.5 or slightly reduced. It may be less than 0.3, but the pressure will be also affected in negative pressure zone. but it will not be flat, and peak is displaced into the negative pressure zone like this. It is present. This is many students they write it type B, but there is peak. You are seeing the peak is written there. In type C, in type B, there will be no peak, but in type C, the peak is there and pressure minus 245. So this is type C. Here the peak is more prominent, but in minus 185. And what is the value? Plus 50 to minus 100. So it is above that. Uh, it looks like this is the picture of resolving acute otitis media. And here this is again the retracted tympanic membrane. So for retraction there are different stages of retraction, most commonly classified by the SADIS. So SADIS 3 classification. In stage 1, basically the eardrum it retracts but doesn't touch middle ear bones. Stage 2, eardrum touches the ossicles. Okay, like this here it is touching. Stage 3, middle ear becomes narrow. If you see here, the space is there, but on promontory it is approximating the middle ear. While in stage 4, the eardrum becomes adherent. So this is retracted tympanic membrane. Whenever you said retracted tympanic membrane, then you have to write its features. The features are given in the book. One, two features I will mention as cone of light, it will be disturbed or absent. Handle of malleus becomes more horizontal. It is like this normally, but now it is become more horizontal. And when this become horizontal, the lateral process will be shifted outward and becomes more prominent. Okay, so these are some of the features, but you can check the book for more detail. In type B tympanogram, there will be a flat curve with no peak, meaning there will be no movement of tympanic membrane is in response to pressure changes from plus 200 to minus 400. It basically indicates the middle ear effusion, any mass in the middle ear, which a big mass, or there is tympanic membrane perforation. So fluid in middle ear, it can be serous, a plain thin water, suppuration meaning pus, or even blood. So most common cause is the otitis media with effusion, tympanic membrane perforation, adhesive otitis media. If we place grommets in the ear also, that grommet, because it will be hole there, and that shows if flat tympanogram is obtained with grommet inside, it means that the grommet is patent. And cerumen inspection, meaning vas, impacted wax. So otoscopy is must be prior to performing this procedure, because if wax is there, then there is no benefit of doing this procedure. Grafts will be, there will be flat or dome shaped line with no compliance. But one important thing for type B grafts is you have to thoroughly check the external canal volume. Why? We'll see. For ECV, if you see, this is the flat graph, but ECV is less than 2, which is normal. No compliance, no pressure. While in this other slide, same flat graph. Peak, no compliance. Okay, pressure, no pressure. But ECV, if you see, it is 3.5. It was 1.5 in the previous slide and 3.5 in this next slide, in this one. So first we'll see the raised one. As you see, if the external canal volume is raised, it means that there is perforation in the tympanic membrane. And why ECV is raised? That is the external canal volume, because now the volume of middle ear and external canal, it is combined, and now two spaces volume, it will be more than only the external auditory canal volume. So in perforation, ECV becomes ECV plus middle ear volume, while in intact tympanic membrane, it's only the external canal volume. So this is a picture of serous otitis media with bubbles, air bubbles here and fluid here. So this is with normal compliance. And this also not normal compliance, normal ECV. In this, the grommet is there, ECV may be raised, and flat graft will be there. You see this blackish eardrum, blood has been accumulated behind the middle tympanic membrane in the middle ear. This is hemotympanum, maybe due to trauma, due to barotrauma. Here you see it is full of pus, again type B. This picture, it is not, but there is no perforation, but it is adhesive otitis media. And this also because the volume is increased due to extra space. So external canal volume will be raised in this one. And sometimes definitely it is difficult to differentiate whether it's a perforation or it is adhesive otitis media. Very rarely, if we perform, in some cases, a positive peak may be appear, meaning the peak may come in the positive range. So middle ear pressure, it is shifted to positive side. Peak present at positive pressure around 100 dpa. This positive shift, it's show early infection or trapped air, meaning in early acute otitis media, the eustachian tube may allow air trapping, leading to increased pressure in the middle ear. So now the pressure in the middle ear has increased due to the air influx in the middle ear, but due to swelling, it is not maintaining that air, or ventilation is not proper. That's why it can lead to positive pressure peak. And also post Valsalva maneuver, forceful blowing with nose pinched, it can temporarily increase the middle ear pressure, or it is also present in the recovering eustachian tube function. Now, clinical applications, it helps to differentiate different causes of conductive hearing loss. As I mentioned, both in ossicular discontinuity and otosclerosis, eardrum will be normal. So, only with history of trauma, it will show towards the ossicular discontinuity, or the pure tone audiometry will further help us guide. Then monitoring otitis media with the fusion, again as I mentioned, you start the treatment with flat graft. If it is shifting towards the type C or type 8, means the condition has improved. Pre and post surgical evaluation, and check the patency of the grommets. Flat graft with high ECV, meaning showing that the grommet which we have placed, they are patent and doing well. So this is the summary chart of the tympanogram. I have placed two charts. You can see both of them. Both are almost same with 1-2 addition in the next slide. So I will explain that one or discuss that one. You can pause it and look this chart. So in type A, there will be sharp peak at 0 dpa, pressure will be normal, compliance will be normal, showing the normal middle ear function, while AS peak will be there, which is of small height, but at around near ambient or 0 dpa in the normal range, but peak will be low. Stiff ossicular system. Then type A with deep tall peaks with normal pressure, but more than 1.5, flaccid TM, thin TM, or ossicular discontinuity. Type C, the peak shifted towards the left in more than minus 100 dpa, because minus goes down, that's why it's written less, meaning 110 will be more less than minus 110 is less than minus 100, so and so forth. That's why it's written less, meaning it is increasing in a way. I hope you understand what I meant to say. But the peak will be either normal or slightly reduced, showing eustachian tube dysfunction or resolving acute otitis media early form. Type B will be the flat curve with no peak and no pressure, but compliance will be low. ECB will be, as I mentioned, will be normal uh, in OME when fluid is there, and high when it is perforation. So limitation does not measure the hearing directly. I mean, when you are performing tympanometry, it's not for the hearing. It is just to check the status of the middle ear. Accuracy depends on the probe seal and patient cooperation. Patient cooperation in a way that he don't have to swallow or yawn or move. It hardly takes more than 10-20 seconds. Affected by external canal issues, if there is wax, if the child is crying too much, it will affect the result, or the ear is discharging, then it can affect the results. So in the end, the summary is that the tympanometry is used to check the middle ear function and produces a graph called tympanogram for compliance in response to pressure change. Types are type A, AS, AD, B, C, where A is normal and rest 4 are abnormal or with pathologies. And it is very a valuable test in diagnosis and management of ear diseases. So I hope you understand. Thank you.